Hello, I am SHUVRO from Medical College KOLKATA, Professional Part 1, and I want to discuss in this video the previous 10 years of autonomic nervous system questions of pharmacology in WBUHS. Okay, so please download the PDF which I send in your WhatsApp groups and open the video and follow the video with the PDF. Okay, so we take 15 topics, most probably 15 topics from the ANS chapter, which complete or which cover every experiment point, mode of action, and long question and short note in your previous 10 years. Okay. So the question is why hyoscine is preferred for the motion sickness. So the question one is why hyoscine is preferred for the motion sickness. So at first you have to write what is the motion sickness. So motion sickness, whenever there is a motion, there is a activation of the vestibular apparatus. When the vestibular apparatus is activated, then CTZ center of the vomiting will be activated. And whenever the CTZ is activated, there is a vomiting. Okay. So there is a link between the vestibular apparatus and the brain by the cholinergic or acetylcholine. So there is the labyrinthine apparatus or vestibular apparatus, and there is the brain or the vomiting center, and there is the link of acetylcholine. So we have to use some drug or anti-acetylcholinergic drug to stop or break the link. Okay. So we use hyoscine. The hyoscine, what is hyoscine? Hyoscine is a natural alkaloid, but it has a property of anticholinergic effect. And it is used prophylactically for the motion sickness vomiting. This broke the link of vestibular apparatus and the brain or vomiting center. So hyoscine is used for the vomiting due to motion sickness. And what is the route? There is a two. One is oral and another is transdermal. Okay. The oral dose is 0.2 mg and it is administered after the symptom has been coming. Okay, so it gives us prevention for 4 to 6 hours. Okay, but in case of transdermal patch, which use behind the pinna, it should be taken before the 4 hour of journey, and it will give protection for 3 days or prevent the motion sickness for 3 days. Okay. So in the PDF, you can show in the page number 2, there is the whole writing of the question. Okay. Why tamsulosin is used in case of benign hypertrophy of prostate or BHP? In question number 2, we know there is alpha 1A and alpha 1B. Two type of receptor. Alpha 1B is present in case of CNS blood vessels. Okay. And alpha 1A is present in case of the bladder neck, in case of bladder neck, and in case of prostate. And noradrenaline is bind to the alpha 1A receptor and causes the contraction of the bladder neck or prostatic urethra. Okay. And there is our tamsulosin. So what is the tamsulosin? Tamsulosin is a uroselective alpha 1A and alpha 1B blocker. Okay. And what it does? It blocked the alpha 1 more than alpha B. The ability towards the alpha 1A and alpha 1B, the ratio vary from 1:7 to 1:38. Okay. So the side effects of the blood vessels is less. The side effects on the CVS is less, but sometimes postural hypertension was seen, but it is less effective. Okay. The tamsulosin binds and block the alpha 1A receptor, and then there is the relaxation of the smooth muscles of the urethra, decongestion of the prostate, and help in case of the binding of urine. Okay, so that's why tamsulosin is used for the BHP or benign hypertrophy of prostate. Okay. So what is acute congestive glaucoma? When there is a severe pain, blurring of the vision, it's an emergency situation, and there is a vomiting. Okay, so we have to prevent this because we have to prevent the optic nerve damage. If we not prevent this, so the patient might be lost permanently their vision. Okay, so we have to stop this. So we not use the atropine sulfate. Why we not use? At first, look at the close angle glaucoma or acute congestive glaucoma. So you have to draw the diagram in your paper. The diagram is not in your PDF. Okay, so look at this diagram. In the close angle glaucoma, there is the narrowing of the iridocorneal angle. Okay, and for that, the clearance of the aqueous humor is not done. Okay, so if by any chance the ciliary muscles come towards the corner and the narrow or the shallow chamber is more shallow, then the problem will be precipitated. Okay, so when it can occur, when there is a pupil dilation was occur, when there is a pupil dilation is occur, then the ciliary muscles come into the corner and the angle is more closed and the glaucoma is precipitated. Okay, so we know atropine is a mydriasis effect, has a mydriasis effect. So if we apply the atropine, the mydriasis effect was done and the pupil will be dilated and the precipitation of the glaucoma is more. Okay, so you have to draw this diagram in your paper and writing is provided in your PDF. Okay. What is the anaphylactic shock? What is the anaphylactic shock? That is the antigen and that is the mast cell. Okay. In the allergic reaction of the antigen and the mast cell, the mediators released from the mast cell, like histamine. Histamine has some effects on our body, like in case of blood vessels, histamine acts. And in the bronchus, the histamine acts. There is the leakage of fluid occurs, and there is the bronchoconstriction. Both days, the laryngeal edema was occurred, and decreasing tension or hypertension. For those effects, the anoxia and the circulatory collapse was done, and this is the anaphylactic shock. You have to draw this diagram in the paper. This diagram is not provided in your PDF, so copy this. Okay. So to stop this, we have to use adrenaline or life-saving drug. So histamine, leakage of fluid, and bronchoconstriction. And the adrenaline is the drug of choice in case of anaphylactic shock. Okay. Adrenaline is the drug of choice in case of anaphylactic shock. Adrenaline acts on alpha 1, beta 1, alpha 2, beta 2, in all four. So let's talk about single. Okay. First is its alpha 1 agonist. So its act on the dilated blood vessels and its help to constrict. So it's fast stop the leakage of the fluid. Okay. And if the leakage of the fluid is stopped, then the laryngeal edema is not occurs and the choking of the patient is not occur. Okay. Now coming to the beta 1 agonist. Pumping oxygen of the heart is increased, therefore the tachycardia is occurs and the cardiac output is high. Okay, so the heart rate, the cardiac output was high, and that's where blood pressure will be maintained. Okay, now coming to the beta 2 agonist. In case of beta 2 agonist, its help in case of bronchial constriction. By beta 2 agonistic action, it causes bronchial dilatation, and the bronchial dilatation is occurs when the anoxia is prevented, and alveoli and oxygenated blood was circulated or increased. Okay, so from all of these actions, the anaphylactic shock is prevented by the adrenaline. Now coming to the route, the concentration and the dose. The route is intramuscular or subcutaneous injection. Coming to the concentration is 1 mg into 10 into 1000 ml of solution. The dose, the 0.5 ml of this solution is used for anaphylactic shock. If the patient is not cured, then we have to repeat 0.5 ml of this solution within 10 minutes. If the patient is not cured, again, then we have to use intravascular intravenous injection of adrenaline, and in that time the concentration will be changed 1:10,000 of the solution. Okay, now we cover the, please copy this picture and draw in your paper. We know there are two types of beta blockers like beta selective and non-selective. The non-selective beta blockers like propranolol is not used or contraindicated in case of peripheral vascular diseases. Okay. Draw this diagram as it is not provided in your PDF. Okay. There is a two receptor alpha 1 and beta 2 in your blood vessels. When the alpha 1 is stimulated, vasoconstriction was done, and when is the beta 2 was stimulated, vasodilatation was done. Okay. And if we use a non-selective beta blockers and the beta 2 was blocked, the vasodilatation is not done, and alpha 1 is upregulated or take the upper hand, the vasoconstriction was done, and for this the peripheral blood vessels may be constricted and ischemia of the limb was done. So that's why the beta blockers is contraindicated in case of peripheral vascular diseases. Okay. Please draw the image as the image is not provided in your PDF. There is the heart, and due to the depressed myocardium, the blood is decreased, and for that, in the renal blood vessels, in case of renal blood vessels, there is a constriction of renal blood vessels and decreased amount of blood, so there is a scanty amount of urine was excrete. Okay, so there is low amount of blood, so the blood pressure will be decreased. So this is the cardiogenic shock, and we use dopamine in case of cardiogenic shock. Why? Because it's have a agonistic reaction in case of D1, D2, alpha 1 and beta 1, and there is a dose variation. In your figure you can see that the D1 is activated when the amount of the dopamine is less than 2 microgram per kg per minute, and if the D1 is activated which present in the more amount of in the renal blood vessels, the vasodilatation also occur. The beta 1 is activated between the 2 and the 10 microgram per kg per minute of the dopamine, and its effect on the heart. And in case of the alpha 1, it's the more amount of 10 milligram per 10 UG per kg per minute, the vasoconstriction was to occur. Okay, so coming to the next picture, please draw this picture also because this is not provided in your PDF. Okay, this is actually the chart. So we have to use between 2 to 5 mg, 5 mu g per kg per minute of dopamine in case of cardiogenic shock. Okay, so that is the dopamine. Its act on D1 and its act on beta 1. Okay, first take look about the beta 1. Okay, in case of beta 1, when the beta 1 is activated, we all know the vasodilatation was occur. And if the vasodilatation also occur, that is the dopamine. Acts on D1 and acts on beta 1. In case of first look at the beta 1, if the beta 1 is activated, the heart pumps more. The systolic BP was high and diastolic BP was slightly high. Okay, so the beta 1 activate the heart. In case of D1, the D1 receptor is mainly present in case of renal blood vessels, and in case of this, the vasodilatation of the occur of the renal blood vessels, the GFR is increased and the urine outflow is increased. Okay, so by the beta 1 and D1 reaction, it's help to prevent the renal parenchymal ischemia. Okay, and the urine outflow and the blood pressure will be maintained. So thus the dopamine is used in case of cardiogenic shock. Okay, so what is epistaxis? Epistaxis is the bleeding from the nasal mucosa. Okay, so coming to the diagram, please draw this diagram. Question number 10. From the intern, from the From the internal carotid artery, the ophthalmic artery is divided, and the branches of the ophthalmic artery, the branch of the maxillary artery and branch of the facial artery, which are the branch of the external carotid artery, is meeting in the area of the nose. This area is called little area of the nose. Okay, there is the little area of nose. We have to use the adrenaline soaked cotton into this area. And what is the concentration? Concentration is 1:10,000. And we use the adrenaline because the adrenaline has an effect on alpha 1, alpha 2, beta 1, beta 2. Okay. So the alpha 1 effect was activated, and the vasoconstriction was done. And the extra junctional alpha 2 action was done, and the blood supply into the little area was decreased. And by this, adrenaline is helped in case of epistaxis. Okay. The atropine. We know the atropine is most potent mydriatic agent. It is slow in acting, but long lasting action. The pupil dilatation was occurred in 30 to 40 minutes, and the psychophagic action was done in 2 to 3 hours, but the subject may be handicapped for 1 or 2 weeks. And we all know the atropine is contraindicated in case of acute congestive glaucoma, we discussed previously, and it is used for refractory test in case of children as they are powerful ciliary muscle. Okay. Now coming to the chart, the mechanism of the atropine sulfate. Okay. Please write down the chart. The atropine sulfate. Two effects. One is passive pupil dilatation, and another is cyclophagic reaction. Why passive pupil dilatation? Because it's not directly pupil dilates. Okay, so there is the pupil. There is two type of muscle. One is sphincter pupil and one is dilated pupil. The sphincter pupil muscle have a receptor, it's a muscarinic receptor M3, and dilated pupil has alpha. Our atropine sulfate blocks the M3 receptor, and the sphincter pupil mainly done the pupil constriction. So the pupil constriction is not done. For that, the passively the dilated pupil is overactivated and the pupil is got dilated. So thus the atropine sulfate helps in the pupil dilation. Okay. Now coming to the cyclophagic reaction. We all know there is the ciliary muscle. There is the names, and there is the suspensory ligament of the names. In the ciliary muscles, M3 receptor was present. Please draw the diagram. And atropine sulfate again block the M3 receptor. And if the M3 receptor is blocked, the ciliary muscles is not contracted, it's become paralyzed, and when it become paralyzed, the whole arrangement of the legs and the subcutaneous ligament will be changed. The ciliary muscles is paralyzed. Lens is flattened. Why lens is flattened? Because the suspensory ligaments is now very tight So the lens is flattened, only the far object can be seen. Okay, so by these two mechanisms, atropine sulfate does, first of all, one is loss of light reflex, and loss of accommodation. Okay, so thus atropine sulfate acts like a pupillalism and cytophysical. So we know there is two type of anesthetic. One is irritant general anesthesia and one is non-irritant general anesthesia. Okay, please copy the flowchart because the flowchart is not given into the PDF. The irritant general anesthesia, when is it used, we have must use the atropine. But when the non-irritant is come, the atropine use is decreased but not stopped. Why? The irritant general anesthesia increase the secretion of salivary and tracheobronchial. For these two type of secretion, the laryngospasm also occur. And we know the atropine, by decreasing the respiratory secretion, prevent the laryngospasm. So we have to administer atropine before the use of general anesthesia, which is irritant type. But in case of non-irritant type, as in non-irritant, but it sensitizes the heart towards the noradrenaline. Okay, and for that the ventricular arrhythmia was done. For the ventricular arrhythmia, there is a vasovagal reaction or vasovagal attack. The heart, the vagus slow down or slowing. Again, the atropine prevent the vasovagal attack. So we have to administer atropine before the anesthesia or as a pre-anesthetic medication. Please copy the flowchart as the flowchart is not given in your PDF. Okay, now the question number 14, the neostigmine. The neostigmine therapeutic uses like myasthenia gravis in post-operative uses, copra-bile, bladder poisoning, and some other drugs overdoses. I have nothing to discuss in that because there is the PDF and the whole discussion is there. I have to discuss the myasthenia gravis, the glaucoma, and the opium organophosphate poisoning after that. So I not go into the details of the neostigmine. Okay, and the question number 15, the different clinical uses of anticholinergic drugs. There is a table of 11 drugs and uses. Please go through the PDF because I have nothing to discuss in the table. Please read out and some questions like motion sickness is hyacine, organophosphorus poisoning, the mid-triatis is already covered into the videos, but I should start the organophosphorus poisoning. Hello friends, now coming to the long question part. The first long question is organophosphorus poisoning. Please understand the concept. So there is a nerve ending. Okay, there is the choline which enters and transform into acetylcholine. Acetylcholine enters into postsynaptic vessels and which release into the synapse and it acts. Okay. We have one enzyme into the synaptic space and that enzyme is acetylcholine esterase which degrade our acetylcholine enzyme. So the acetylcholine esterase breaks our acetylcholine enzyme, but there are some blockers which blocks the acetylcholine esterase enzyme. These blockers is block the acetylcholine esterase and therefore the acetylcholine amount is increased into the synaptic space. And if the acetylcholine enzyme is amount is increased, then it's act on the some cholinergic receptors, like its acts on inhibin receptor, its acts on inhibin receptor, its acts on M1, M2, M3. Okay. When it act on M3, then it's cause constriction of pupil, secretion increase. Then if the secretion is increased, there is a diarrhea. Okay, there's some bronchoconstriction. This occurs due to the high action on the M3 receptor. Okay, there may be immunity intolerance in case of inconsistency in case of M3 block. M3 upregulated. Come to the M2. If the M2 is overstimulated, then the decrease in heart rate and decrease in blood pressure. Okay, and if the M1 is high, then the amount of HCl is increased, and for that, peptic ulcer disease was done. Come to the NM receptor. If NM receptor is stimulated, then heart rate and BP was increased, which seen rarely. And if the NM receptor is stimulated, then muscle weakness. There's the action of the acetylcholine into the receptors. Okay. Now, coming to the organophosphorus. What is organophosphorus? The organophosphorus is a indirectly acting parasympathetomimetic drug. So it is an indirectly acting parasympathetomimetic drugs. Why indirectly acting? Because it's block the acetylcholine esterase enzyme. Why parasympathetomimetic drugs? Because the acetylcholine reactions is increased. Okay. So there are two indirectly acting parasympathetomimetic drugs like organophosphorus and carbamates. Those are irreversible acetylcholine esterase blocker. Irreversible. Now coming to the organophosphorus. The whole actions organophosphorus leads to acetylcholine increase, and then its acts on NM, M1, M2, M3, and there are some certain features like pinpoint pupil, and there are something called secretion increase. Both are seen in case of organophosphorus poisoning. Okay. So coming to the acetylcholine esterase. Please draw the diagram. This is the acetylcholine esterase enzyme. Okay. There are two sites. One is aesthetic, one is anion. The acetylcholine binds to the aesthetic site and it's degraded. Organophosphorus come and bind to the aesthetic site through phosphate bond. So, thus the organophosphorus bind to the aesthetic site and the acetylcholine aesthetic work is down regulated. Okay. But when there is the PU43 minus bond is present, then it is a reversal. But after some time, the PU4 bond is not there. There are some strong bonds made between aesthetic site and the organophosphorus, and this is called aging. And if the aging is done, then different to break, there is very difficulty to break these types of bonds, and now this is irreversible. Okay, so what is the sequence? The sequence is, first of all, in the aesthetic site, the organophosphorus come and bind through the phosphate bond. Then the aging was done. What is the aging? Aging of some strong bonds formation which are difficult to break. Okay, in the aesthetic site. Now coming to the treatment part of the organophosphorus poisoning. There is two types of treatment. Okay, one is atropine. We can use atropine, or we can use the acetylcholine esterase reactivators. So, what is the treatment procedure? Okay, first of all, we know in the synapse there is more amount of acetylcholine, and acetylcholine esterase enzyme are blocked. And there are our receptors. We can use in two types. One, we can directly block the receptors. That's why acetylcholine cannot bind to the acetylcholine receptors, and thus we downregulate the organophosphorus effects. And this type of action was done by atropine. Otherwise, we can reactivate these acetylcholine esterase enzymes. That's why they broke the acetylcholine, and therefore we can downregulate the organophosphorus poisoning. Okay, but the reactivation of the acetylcholine esterase enzyme is possible when there is aging is not done. And the other way, when there is a phosphate bond is present, then we can reactivate our acetylcholine esterase enzyme. Okay, so atropine mainly blocks the mastering receptors, not NN or not NN. So atropines cannot reverse the muscle weakness, but it can reverse the organophosphorus poisoning in the muscarinic receptors. So atropine is the drug of choice in case of organophosphorus poisoning and carbamate poisoning. I will discuss all of it later. Okay. And acetylcholine reactivators are auxins, like pralidoxin, diacetyl monoxide. Okay. So how auxin works? Actually, there are two sites I previously talked in acetylcholine esterase enzyme. One is the esterase and one is the anion. In the esterase side, there is our phosphate bond and there is our organophosphorus. And oxime come and bind to the anionic side. Okay. So we have to open the anionic side for oxime binding. And then oxime bind to the organophosphorus, which is a strong bond. The phosphate bond is broken into the esteric side and organophosphorus oxime is removed from the site and the acetylcholine esterase enzyme is reactivated. Okay. So this is the mechanism of the oxime and the atropine into the organophosphorus positive. Okay. So there is two type of oxime. One is palidoxime and diacetyl monoxime. The palidoxime it's only act on periphery and diacetyl monoxime can act periphery plus central. Okay. Now coming to the carbamate. In case of carbamate poisoning, the carbamate binds to the both side, esteric and anionic side of the acetylcholine esterase enzyme. This is the carbamate. So in this case of carbamate, oxime cannot bind to the anionic side. So in case of carbamate poisoning, again the atropine is the drug of choice. So in the question number 11, which I not discussed previously, in the question number 11 is we read from the PDF and try to mug up the concept from this long question part. Okay. Autoimmune disease, we all know. And one antibody is formed. The antibody from against the NM receptor, which is present in the neuromuscular junction and bind to the NM receptor and become NM under stimulated. For that, the muscle weakness occurs. So, there is another condition which is called cholinergic crisis. In case of cholinergic crisis, the NM receptor is overstimulated. And for that, again, the muscle weakness occurs. So, in this lecture, I will discuss the myasthenia gravis treatment and how to differentiate myasthenia gravis to the cholinergic crisis. Okay. Before the myasthenia gravis treatment, I want to discuss some acetylcholine esterase blockers, but these are not irreversible. They are reversible. So, acetylcholine esterase blockers. There are two types. One is water soluble, one is lipid soluble. The water soluble is tertiary amine. Okay, and because it is a tertiary amine and it is a non-polar plus non-ionic, it can cross blood-brain barrier. Okay, and it can cross membranes. So the water-soluble acetylcholine esterase blockers we can give orally, as it can cross GIT membrane. It can cross our eye membrane, so there is a pupil effect. Okay, and they can cross blood-brain barrier, so there is a central effect. Coming to the lipid soluble part, the lipid soluble is a tertiary amine. Sorry, it is a quaternary amine. It's ionic and polar. It cannot cross blood-brain barrier or any membrane. It cannot give orally. It cannot cross GI membrane. No pupil effect, and there is no CNS effect. Okay. Now coming to the examples. In case of water soluble, there is a physostigmine. The physostigmine, it can cross the blood-brain barrier, it can reach the central nervous system, and it can cause some effects on the CNS. But it is a drug of choice of atropine positive. Okay, and there are some lipid soluble drugs. The lipids, one is neostigmine, second is pyridostigmine, and third is hydrophonium. Okay. So coming to the question like physostigmine, why is not used and why neostigmine is used? The physostigmine can cause blood-brain barrier. Okay. So there is some CNS effects. First of all. Second thing, neostigmine cannot cross blood-brain barrier and direct effect on NM receptors. 2 points. And third point is physostigmine has a CNS side effect, and most of the physostigmine found in the CNS because it's cause blood-brain barrier. And as this cannot cause blood-brain barrier, so there is no effect on GIT, no effect on the pupil, but there is the effect on pupil and effect of GIT is found. So that's why physostigmine is not used, neostigmine is used. First of all, there is some cholinergic crisis and there is myasthenia crisis. Okay. In this case, there is the muscle weak because NM receptors are overstimulated. In this case, muscle is weak, but in this case, NM receptors are under-regulated. So, if we stimulate these NM receptors, as it is overstimulated, the muscle weakness is increased. But in this case, the muscle weakness decrease. There is improvement. There is a worsening. So we have to use some small acting drugs for this test, and this test is called hydrophonium test. Hydrophonium has a short time action, like its action 10 minutes, and it is a short acting. So when we enter in hydrophonium, after 10 minutes, if there is the condition is increased, the worsening of the condition, then it is a cholinergic crisis. And if after 10 minutes there is the improvement, so this is a myasthenia crisis. Okay. Now, coming to the long acting, lipid soluble drugs like pyrostigmine and neostigmine. Pyrostigmine is longer acting than neostigmine. Okay, and the neostigmine its act on, and also pyrostigmine, its acts on NM receptor M1, M2, M3. That's why there are some side effects. And as it works on NM receptor, so there is a decrease of muscle weakness. To decrease the side effects on the muscarinic receptors, we can add atropine. To block the muscarinic receptors. So, what is the regimen of myasthenia gravis? So, for the myasthenia gravis, we can use neostigmine plus atropine for myasthenia gravis. Okay, we can use cobra bite, the same neostigmine and atropine. But in case of post-operative paralytic ileus, we can use only neostigmine, and post-operative urinary retention, we can use only neostigmine. Okay. So I will discuss the organophosphate poisoning, the myasthenia gravis, the neostigmine, the pyrostigmine, the physostigmine actions, and the atropine actions. Okay. So please read out the question number 7, 8, and 14 question, which I skipped in the previous day.